acute inflammation is neutrophil. But in chronic inflammation, there are different cells. So the different patterns can be there, different cells. So macrophages, lymphocytes, plasma cells. So that's why it is more heterogeneous. And the clinical signs we discussed last week, the 5 clinical signs: rubor, tumor, dolor, calor, and loss of function. In chronic inflammation, then the redness slightly disappear, and the rise in temperature also disappear, but the swelling, pain, and loss of function remains. And then chemical mediators, they are also present here also. Then we discussed last week about phagocytosis, opsonization, and the killing mechanisms for microorganisms, oxygen dependent, oxygen independent, oxygen dependent mechanisms using reactive oxygen species or free radicals. So definition: inflammation is response of living tissue to injury. So in chronic inflammation, it is chronic response to injury, and it is usually associated with fibrosis, or there is some sort of repair is also going along with the injury and inflammation. That's why there is fibrosis. So chronic inflammation is a chronic response to injury associated with fibrosis. Then now we are going to discuss about the causes, or how does it arise. So it can follow acute inflammation if the injury is too severe. If the injury is less, complete resolution occurs. If the injury is severe, then it can become chronic. Like an abscess develops following an acute inflammation. If it is not drained, or if it is too severe, it becomes chronic. And the next or commonest one is it arises de novo. It arises, some of the inflammations are chronic, like tuberculosis. Then chronic hepatitis, hepatitis B, hepatitis C, leprosy, all these are chronic inflammations, autoimmune diseases. Then the third group, it occurs along with the acute inflammation, repeated acute inflammation or persistent injury. Please. Then it is a chronic response to injury associated with fibrosis. Then tissue changes, or how does it look like? The changes, it is mainly the microscopic appearance mainly depends on the type of inflammatory cells involved. So there are, and predominant cell type gives us the clue to the etiology of the inflammation. The first and most important, first one is macrophages. Then macrophages, if you please listen here or keep quiet, that's better. The macrophages, and then next one is lymphocytes, then plasma cells, then eosinophils, fibroblasts. So different cells are involved in chronic inflammation. So first is macrophages. Macrophages are large cells. So the lymphocytes are the same size of a red blood cell. Macrophages are large cell. They have got usually clear foamy cytoplasm. But these cells, these large cells are macrophages. They have got these dark particles. They are phagocytosed particles. Macrophages are derived from monocytes. They are produced within the bone marrow and then comes into the blood and circulates in the blood for a few days as monocytes. Then from the blood they move into the tissue. Once it is inside the tissue, it is called histiocytes or macrophages. And there are they move into different organs. In the lung, it is alveolar macrophages. In the liver, it is called Kupffer cells. And then in the spleen, it is called reticuloendothelial cells. They are all macrophages or histiocytes. They are all derived from monocytes. They are all produced in the bone marrow. The difference from the neutrophil is that neutrophil's lifespan is only 2 to 3 days and it is end cell or it can't replicate. But the macrophage, it is within the tissue, it can survive for months and then it can replicate as well. It can proliferate. So it is a very effective mechanism of defense, very effective. It can defend the body very effectively because it can replicate and its lifespan is long. And the functions of macrophages are many. Macro means large, phagocytosis means phagocytosis. So it is a large eater. That means macrophage means. So first, as the name indicates, the function is phagocytosis. Phagocytosis and destruction or killing of the microorganisms. Then one important function is it is the antigen presenting cell, or it presents the microorganisms to the immune system or lymphoid tissue. Then the immune system gets activated and they produce antibodies or other mechanisms, and it is the antigen presenting cell. Then it produces many cytokines or many chemical mediators. Cytokines means chemical mediators produced by the cells and which influences other cells. So it produces many cytokines like interleukin, tumor necrosis factor. They are involved in inflammation. They produce inflammation. They produce another sort of set of cytokines which are called growth factors, like epidermal growth factor, fibroblast growth factor, platelet derived growth factor. So they influence fibroblasts and it stimulates collagen synthesis, so fibrosis. So it is involved in a sort of healing. So some of the cytokines are involved in inflammation and some are involved in healing type, fibrosis. So the functions of macrophages, phagocytosis and killing, antigen presenting cells, and then lot of cytokines. There are lots of cytokines produced by macrophages, in maybe more than 100. Then the next cell of chronic inflammation is lymphocytes. The lymphocytes are the size of a red blood cell, about 7 to 8 microns. And under light microscope, the cytoplasm, because the cytoplasm is scanty, it is not visible. We are seeing only the nucleus. These in dark dots are the lymphocytes. There are different types. They are B lymphocytes, T lymphocytes, then another group called natural NK cells or natural killer cells. So there are and the B lymphocytes, when it is activated, it becomes plasma cells. B lymphocytes become plasma cells and they produce antibodies, and the antibodies destroys bacteria, or it can be used as, it can be an opsonin as well. Last week we learned opsonization, isn't it? Opsonization stimulates phagocytosis. So B lymphocytes differentiate to plasma cells and produce antibodies. And then T lymphocytes. T lymphocytes are also different types of T lymphocytes, T helper cells, T cytotoxic T lymphocytes. So helper cells produce many cytokines which influences other lymphocytes and macrophages, and so they produce a lot of cytokines like gamma interferon, which is involved in hypersensitivity, delayed hypersensitivity or granuloma formation. Then cytotoxic T cells, it kills the virus infected cells or tumor cells. So they can directly destroy the infected cells. So lymphocytes, B lymphocytes, T lymphocytes, they are involved, B lymphocytes involved in antibody production, and T lymphocytes, helper cells, cytotoxic cells. Cytotoxic cells kills the infected cells. Then the same way NK cells or natural killer cells, they also can damage the, kill the infected cells and tumor cells. Then the third group is plasma cells. This is a plasma cell. Plasma cell, it is larger than a lymphocyte and it has got an eccentrically placed nucleus. Nucleus is towards one side of the cell, and the cytoplasm is like a heart it is sitting around, and typically there is a perinuclear halo or perinuclear hole for a plasma cell, and the plasma cell is produced from B lymphocytes and it produces antibodies. And many plasma, this type of cell gives us a clue to regarding the etiology. In rheumatoid arthritis, there are a lot of plasma cells. Then the fourth type of cell is of chronic inflammatory cell is eosinophil. Eosinophil is a granulocyte with a prominent orange granules. This is an eosinophil. These two are eosinophils, and they have got a bilobed nucleus, single nucleus with two lobes. So it has got a bilobed nucleus, and so it is typically described as a spectacle shaped or speck shaped nucleus for eosinophil. And many eosinophils are predominant in allergic reactions, parasitic infestations, worm infestations, because the protein from the eosinophils can kill these parasites or worms. So eosinophils are predominant in allergic reactions and parasitic infections. And the next one is fibroblasts or myofibroblasts. They are involved in fibrosis. So chronic inflammation, there is fibrosis, and so fibroblasts are the. And then the next big group is giant cell. There are different giant cells, different types of giant cells. Giant cells are multinucleated cells. They are big cells. They have got multiple nuclei and they are formed by the fusion of macrophages. When the organism is difficult to digest or kill, they form the giant cells. Or when the phagocytosed particle is insoluble particles like a keratin, these giant cells, histiocytes fuse to form giant cells. There are different types of giant cells. One is Langerhans type giant cell. Langerhans type giant cell. This is Langerhans type giant cell. This is typically seen in tuberculosis, where the nuclei are arranged in a horseshoe pattern or U-shaped pattern at the periphery. And it can be seen in sarcoidosis and Crohn's disease as well. So it is typically seen in Langerhans giant cell, typically seen in tuberculosis. Then the next one is foreign body type giant cell. In foreign body type giant cell, these are different foreign body giant cells. The nuclei are several nuclei arranged haphazardly in the cytoplasm. And so this foreign body can be seen within the foreign body giant cell, or the foreign body can be surrounded by these foreign body giant cells. In this one, this is keratin, and the giant cells are surrounding that keratin. When the hair follicle is ruptured or when the epidermal cyst is ruptured, the keratin is released into the tissue. Even though keratin itself, when the keratin is on the skin surface, it is not a foreign body. When it gets into the tissue, it acts as a foreign body. Or it can be due to suture materials, or as foreign body got into the body like a tiny splinter, or that can give rise to foreign body giant cell. And then the next one is two-tone type giant cell. In this, the nuclei are arranged in a wreath-like pattern in the center, and it is all surrounded by cytoplasm. The foamy cytoplasm around as well. So this is seen where there is a lot of fat or lipids, like xanthogranuloma and then fat necrosis. So this two-tone type giant cell is seen. So we described three types of giant cell: Langhans giant cell, foreign body type giant cell, and two-tone type giant cells. So we have described different types of inflammatory cells. Macrophages, they are antigen presenting cells. They produce cytokines.
What is the trigger? Why macrophage is used? What's the trigger?
If it is they say that it is when there is a insoluble particle is like a foreign body, like a silica, or if it is that it is insoluble, so it is difficult for the macrophage to destroy. Then the frustrated phagocytosis, or they fuse together to form giant cell and try to attack it. And rheumatoid arthritis, we see many plasma cells. Then in leishmaniasis, we see a lot of macrophages. So the predominant cell type gives us a clue regarding the etiology. The same way giant cell types, Langhans giant cell, tuberculosis, like that. Then coming to the effects of chronic inflammation or consequences: fibrosis, impaired function. Sometimes the function can be, it stimulates or increases the function. Then atrophy, then autoimmune diseases or stimulation of immune responses. Fibrosis is usually, example is chronic cholecystitis. Peptic ulcer, and in cirrhosis there is fibrosis. Chronic cholecystitis, we discussed acute cholecystitis last week, isn't it, in the workbook. So chronic cholecystitis, it's a very common disease, and it is usually seen in young females. It's typically seen in fat, fertile women in 40s. That's what they say, fat, young women who are fat. And the cause of cholecystitis is gallstones. Cause is gallstone. This is gallbladder, right hepatic duct, left hepatic duct joined together to form the common hepatic duct. Gallbladder, the narrow part is the cystic duct. So the gallstone usually lodges in the cystic duct and it obstructs the gallbladder flow of bile, and the gallbladder gets distended, and when it gets obstructed it becomes ischemic, and then the bacteria easily involves, and then acute cholecystitis happens, and then repeated obstruction leads to repeated acute cholecystitis that leads to chronic cholecystitis. So this stone can move down. That's how it becomes ascending cholangitis. When it is going down here, if it lodges at the common hepatic duct or down, it can cause ascending cholangitis and spreads in the liver. Last week we discussed that in the workbook.
Sorry, so the blockage with the gallstone, is that what then causes the acquirement of bacteria.
Yeah.
You said.
Yeah. Obstruction leads to ischemia, and then bacteria gets in, and usually gram-negative bacteria, and then leads to inflammation. So repeated acute inflammation leads to chronic cholecystitis. This is a gallbladder with many stones inside. There are different types of stones: pigmented stones, cholesterol stones, mixed stones. It is depending on the constituents of the, when there is an imbalance of the, or when there is the balance of different ingredients change, these stones happen. And the gallbladder shows when there is a thickened fibrosed gallbladder happens because of repeated inflammation, there is fibrosis. This is the light microscopic appearance. There are a lot of inflammatory cells. Ulcerated mucosa, there is chronic inflammatory cells. The muscle is all replaced by fibrous tissue. Muscle is thickened and replaced by fibrous tissue. And the glands are all distorted because they are destroyed and regenerated. Then it becomes distorted. Repeated obstruction leads to acute inflammation, that leads to chronic inflammation or chronic cholecystitis, and then fibrosis. Another one example for fibrosis in chronic inflammation is peptic ulcer. This ulceration is due to imbalance of imbalance of acid and peptic attack and impaired mucosal defense. So it could be due to increased acidity or increased acid and peptic attack or impaired mucosal defense. The gastric mucosa is protected by a thick layer of mucus and then epithelium. So when that is destroyed, when that mucus gel is destroyed, then the acid attacks, because a lot of acid is in the stomach, that attacks the epithelium and mucosa. So the commonest site causes are Helicobacter pylori, hyperacidity. So hyperacidity can be due to Zollinger-Ellison syndrome, which you will learn later. Then it could be due to drugs, non-steroidal anti-inflammatory drugs like aspirin. So these drugs leads to, is because of the mucosal defense, impaired mucosal defense. Because we learned that the aspirin last week, that its mechanism is impairing the production of prostaglandin synthesis, arachidonic acid metabolites. So prostaglandin is important in mucosal defense. So the commonest site is gastric antrum, and the second is first part of duodenum. When there is, because the antrum is the narrow part of the stomach, gastric body, and then it becomes a gastric antrum. Because that is a narrow part of stomach, when there is fibrosis, it leads to obstruction, gastric or so that is called narrowing or pyloric stenosis. So peptic ulcer can lead to pyloric stenosis. This is the gross appearance of the peptic ulcer. We can see ulcer with punched out or sharp edges, and then there is necrotic material. This is the scanner view or light microscopic appearance. This is the normal mucosa on either side, and this is the ulcerated area with necrotic material and inflammatory cells and fibrosis at the base. This is the diagrammatic representation. This I took from the Robbins. So this is a normal, there is a thick layer of mucus and epithelium, it protects the mucosal defense, and there is injury because of hyperacidity or peptic acid and peptic attack. So when there is an injury, it leads to inflammation and ulceration. So this is the diagrammatic representation of the peptic ulcer, necrotic material, inflammatory cells, granulation tissue and fibrous tissue. So the peptic ulcer leads to fibrosis and pyloric stenosis and obstruction. So previously the treatment for pyloric stenosis is used to be GJ vagotomy or gastrojejunostomy and vagotomy, and nowadays that surgery itself is very unusual. It was a common procedure 10-20 years ago. Now it is very unusual because there are a lot of new drugs which controls the hyperacidity, and there are treatment for Helicobacter pylori. So so this procedure itself is now very uncommon. And then the next one is impaired function. Example is inflammatory bowel disease. Inflammatory bowel disease is idiopathic, unknown etiology, and it is mainly two types, or it has two types, ulcerative colitis and Crohn's disease. And the patient presents with diarrhea, with blood and mucus, then other symptoms like pain, depending on whether it is ulcerative colitis or Crohn's disease. Ulcerative colitis, there is usually it is diarrhea with blood and mucus. This is the gross appearance of Crohn's disease. It is typically called cobblestone appearance. These raised areas are the normal mucosa, which is swollen, and then in between these linear ulcers. So that is the cobblestone appearance typically seen in Crohn's disease. In Crohn's disease, it is a terminal ileum is involved. So small bowel is involved in Crohn's disease mainly, and it can involve the large bowel as well. Ulcerative colitis, involves the large bowel. And Crohn's disease is skipped lesions or patchy lesions. There is a segment of involved area, then a normal mucosa, then another area of involved. So it is skipped lesions. But ulcerative colitis, inflammation is continuous, and it usually starts from the lower end or rectum. So, and in Crohn's disease, inflammation can be panmural. It involves mucosa, submucosa and muscle coat. Whereas ulcerative colitis, inflammation is superficial or mucosal. Ulcerative colitis affects the large bowel. Crohn's disease affects the small bowel, mainly small bowel, and it can affect the large bowel as well. So this is a normal colonic mucosa. The crypts are all arranged parallel, and there is some amount of inflammatory cells are also there. This one. So Crohn's disease affects the small bowel and large bowel. Ulcerative colitis mainly large bowel, and it is continuous inflammation. Ulcerative colitis. Crohn's disease is skipped inflammation. And so this is light microscopic appearance of ulcerative colitis. This one. Here the crypts are not arranged parallel, it is all distorted. This is the normal appearance, crypts are all parallel. In this one, the crypts are all distorted, that was like villi-like appearance are all distorted. And this is the higher power view. You can see some of these crypts are dilated and filled with neutrophils. and it is called cryptapsis. When the neutrophils are on the epithelium, lining epithelium, it is called cryptitis. So in an ulcerative colitis, there is cryptitis, cryptapsis, crypt distortion, and lot of inflammatory cells. And the inflammation is superficial or mucosal inflammation. So that is the same, this slide shows the same thing, superficial, and it presents with diarrhea and bleeding, ulcerative colitis. Crohn's disease, it is transmural or panmural inflammation, and there is usually fibrosis. In Crohn's disease, there is usually fibrosis, because fibrosis, there is stricture, and it can lead to stricture, fistula, and they are the complications of it. Then, and next example is cirrhosis of liver, and that is there is fibrosis and impaired function. In cirrhosis, there is inflammation, destruction of hepatocytes, fibrosis, and nodular regeneration that leads to cirrhosis. There is chronic inflammation, destruction of hepatocytes, and then there is fibrosis and nodular regeneration. Because of the nodular regeneration, it is studded with nodules. This normal architecture is replaced by nodules. That is the cirrhosis. And the common causes are alcoholic cirrhosis, then chronic hepatitis like hepatitis B, hepatitis C, then other causes are there, primary biliary cirrhosis. So these are all cirrhosis. There is destruction of hepatocytes, chronic inflammation, destruction of hepatocytes, then fibrosis that leads to cirrhosis. This is the normal liver. It is smooth, dark brown. Then this is cirrhotic liver. It is studded with nodules, that is cirrhosis. This is the normal light microscopic appearance of liver tissue, central vein, and all these cords of hepatocytes in a very regular pattern. It has got that radiating cords of hepatocytes. But in cirrhosis, this is cirrhosis, the nodules of regenerating hepatocytes surrounded by fibrous tissue. That normal architecture is completely lost, and there is a lot of nodular regeneration and fibrosis. This is a special state. So this loss of normal architecture and fibrosis leads to obstruction of portal vein. Then the venous drainage is impaired, or portal vein is impaired. That leads to portal hypertension. Portal hypertension, esophageal varices, and all these things you will learn later. Portal hypertension, and it leads to cirrhosis. There is, because of hepatocyte destruction, there is liver failure, and also it predisposes to hepatocellular carcinoma. Then the next one is thyrotoxicosis. In this one, there is increased function, impaired function, there is increased function in this one. It is an autoimmune disease. The patient presents with thyrotoxicosis, signs of thyrotoxicosis, and enlarged goiter, enlarged thyroid. So there is a goiter and there is thyrotoxic signs. They have got exophthalmos, thyrotoxicosis like palpitation, sweating, tremor. So, and it is autoimmune disease. The autoantibody is long-acting LATS, or long-acting thyroid stimulator, and that is it's same as thyroid stimulating immunoglobulin. That's the new name for the same thing. And it is an antibody. It acts on the TSH receptor, and it acts like TSH. So because it acts like TSH, or it stimulates the thyroid stimulating hormone TSH. So there is increased thyroxine, increased T4 and T3. When the thyroxine is increased, the TSH will be reduced automatically, isn't it? So this autoantibody acts on the TSH receptor and it acts like a TSH and increases the T4, T3 and gives rise to the appearance of thyroid and gives thyrotoxicosis. This is the light microscopic appearance of the thyroid in the Graves' disease. Thyrotoxicosis is also called this autoimmune thyrotoxicosis is also called Graves' disease. There is scalloping of colloid. Then the thyroid epithelium becomes tall and there will be lymphoid infiltrate. It is not seen here because it is already treated. Then the next one is example for atrophy. It is chronic this is chronic gastritis, autoimmune gastritis or atrophic gastritis. This is a normal gastric mucosa. The quality of stain is poor. And there are in gastric body mucosa there are a lot of chief cells and parietal cells or specialized epithelium. The specialized glands or specialized epithelium, parietal cells produce acid, chief cells produce pepsin. In autoimmune gastritis, you can see there are a lot of lymphocytes, and in that area the specialized glands are all destroyed or gastric atrophy happens. There is autoimmune gastritis, there is an antibody against the parietal cells and intrinsic factor. So the parietal cells are destroyed. The parietal cells are destroyed, then that leads to hypochlorhydria because there is reduced acid production, isn't it? Atrophic gastritis. And because of B12 deficiency, intrinsic factor is involved in absorption of B12. So when there is intrinsic factor is destroyed, that leads to B12 deficiency as well. So this is atrophic gastritis. Then the next one is, and a very common one is rheumatoid arthritis. It is also an autoimmune disease. It is a very common and it is a common chronic inflammatory, systemic inflammatory disease. And it invariably affects the joints. But other organs can be involved, but may or may not be involved. Joints will be invariably involved in rheumatoid arthritis. And it is usually seen in women. And it usually affects the small joints. So it usually affects the small joints of hands and feet. So like a metacarpophalangeal or interphalangeal joints. And the joints are deformed because of the chronic inflammation and fibrosis. So this is the synovium of it first affects the synovium. Then it erodes into the adjacent cartilage. So the synovium is usually there is no, in normal state, in synovium is flat and there are no inflammatory cells. In this one the synovium is hyperplastic like a villi-like projections. This is synovium is hyperplastic and there are a lot of lymphoid cells and plasma cells. So that is rheumatoid arthritis. And there is it is an autoimmune disease. The autoantibody is rheumatoid factor. And it can be systemic, it can involve lymph nodes. Usually there is a lymphadenopathy, splenomegaly, rheumatoid nodules can be occur on the skin, subcutaneous tissue, in the lung, it can be there, and it can produce chronic rheumatoid arthritis, can produce amyloidosis, Then the next and a big group of chronic inflammation is, an important group of chronic inflammation is granulomatous inflammation. Granulomatous inflammation means a chronic inflammation with a granuloma. So what is a granuloma? Granuloma is an organized collection of epithelioid cells. Organized collection of epithelioid cells. Epithelioid cell is a modified histiocyte or modified macrophage. So these are epithelioid cells, means epithelium-like. So these are modified macrophages or activated modified macrophages, epithelioid cells. They are slightly elongated. They have got eosinophilic cytoplasm. They are more close together. So they are more like epithelium-like, close together. So it is epithelioid cells. So a granuloma is an organized collection of epithelioid cells. It is, we can broadly divide the granulomas into immune granulomas and foreign body granulomas. The important one is immune granulomas. The other is foreign body granulomas. These granulomas are also formed when the ingested particle is insoluble or difficult to digest, or when the microorganism is difficult to handle or kill. So that is the reason for the granuloma formation. So they group together and try to defend. So deal with particles which are poorly soluble, like foreign bodies. So that leads to foreign body granulomas. Or organisms which are difficult to destroy, like Mycobacterium tuberculosis, Mycobacterium leprae. They have got a special coat, lipid coat, that prevents the easy digestion by ordinary macrophages. So they cannot be. So the causes of granulomatous inflammation: foreign material, foreign body granulomas, then infections like Mycobacteria, tuberculosis, leprosy, fungal infections. Then a group of unknown causes like sarcoidosis, vaginaceous granulomatosis, Crohn's disease. Crohn's disease we have already described, isn't it? So this is foreign body granuloma. You can see a lot of foreign body giant cells. These are all foreign body giant cells. Then this clear area, it is a foreign material. It is near the, when there is a prosthetic knee replacement or hip replacement, where there is a prosthesis, and after a long time there is wear and tear, and these particles will be released slowly into the tissue, and there will be foreign body reaction. So this is under polarized microscopy, these particles are polarized. So it is a foreign body granuloma reaction. Then the next one is immune granuloma, or the granulomatous infections, and the first and most important one is tuberculosis. This Mycobacterium tuberculosis has got that special coat or special lipid coat that gives it this special staining properties, and also it gives protection from the it protects the bacteria. It doesn't produce any toxins or enzymes. So when the bacteria enters it spreads through the respiratory tract or airborne infection. Then it comes across the alveolar macrophages. But this bacteria has got that special property, and so it is phagocytosed, it is within the phagosome, but it blocks the fusion with the lysosome. So it is protected by itself, by blocking the fusion of phagosome with lysosome. That fusion needs to be, or phagolysosome should be there to produce the free radicals and other enzymes to kill the bacteria. So that doesn't happen, and so the bacteria proliferates within the alveolar macrophages, within the phagosomes, and the bacteria can spread locally or it can get into the blood. This picture is just for the how it works. That's it. In 2 to 3 weeks, this cell mediated immunity is formed, or the antigen presenting cell, it presents the bacteria to the lymphoid cells, T lymphocytes, and they produce interferon. This interferon activates the macrophages. So this activated macrophages is very powerful, very strong. So now the block doesn't work. The bacteria can't. Now this activated macrophages, the phagosome fuse with the lysosome. So the bacteria can no more block the fusion of phagosome with the lysosome. So the activated macrophages is very powerful, and that leads to phagolysosome formation, and then as we discussed last week, these free radicals are produced and it destroys the bacteria. So this interferon is also probably the cause for the formation of epithelioid cell, which is a modified macrophage. So that's it. And this activated macrophage produces a lot of chemokines and inflammatory mediators, and that leads to the formation of this granuloma as well. So this is, just to get you don't have to learn all these things, but this to get an idea of how it works. So this is in tuberculosis, there is a caseating granuloma. At the end of this, the bacteria, destruction of bacteria, and then this macrophage gets digested or gets destroyed. When it gets destroyed, the enzymes are released, and then as like a collateral damage, it destroys the adjacent tissue. That leads to this necrosis.
But what causes the caseation?
What causes the?
The caseation.
Caseation is because when the phagosome fuses with this lysosome and phagolysosome is formed and it destroys the bacteria. So the phagolysosome contains these free radicals and enzymes, that are protease, collagenase, which destroys the bacteria. So at the end of this process, the macrophage itself gets destroyed, and so the enzymes are released into the tissue. So it destroys the adjacent tissue. So it leads to the collateral damage of necrosis.
But why are some granulomas not caseating?
Why it is caseating type necrosis, that I don't know. Why it is, this one is case. Maybe because this destruction is this way, and in tumor necrosis and other things it is due to ischemia. This one, the cause is this way, this digestion in a way, isn't it? The enzymes are released and the tissue is destroyed. So this caseation necrosis is, it is a gross appearance, it is a cheesy appearance. So caseating granuloma is seen in tuberculosis. The cause of caseating granuloma is tuberculosis. So this is caseation and surrounded by epithelioid cells or granulomatous reaction. So caseation is homogeneous eosinophilic material. We see under light microscope as homogeneous eosinophilic material without any nuclear debris. So this is caseation, and these are epithelioid cells and lymphocytes, caseating granuloma, seen in tuberculosis. This is lung with a caseating granuloma, and there is a Langhans type giant cell. This is also tuberculous granuloma or caseating granuloma. Diagrammatic representation. You can see caseation, epithelioid cells, Langhans giant cell with a horseshoe pattern, nuclei arranged in a horseshoe pattern. Then the outcome of this, it can be healed, there can be fibrosis and scarring of the lung tissue where it is involved, or it can erode into bronchus and leads to spread to the rest of the lung, or it can through the sputum, it can affect the gastrointestinal tract, or it can spread into pleura, or it can spread into bloodstream. Then it spreads to different organs. Miliary tuberculosis, it can go to liver, meninges. You can look at the picture later. And then it's a BCG. There is a vaccination for tuberculosis, and it is the BCG. BCG vaccine contains live attenuated Mycobacterium bovis, or which is not harmful to the human being. So that is used in BCG vaccine, and that also produces the same sort of tuberculous granuloma. Then there are other causes like leprosy, syphilis, fungal infection. This is an example of another granulomatous inflammation where we did some fungal stain, methenamine silver, and it is positive. Lot of yeast forms of bacteria are seen. So that is histoplasma. Then other causes of granulomatous inflammation of unknown etiology is sarcoidosis, and it is usually seen in sarcoid. It is non-caseating granuloma. In tuberculosis, it is caseating granuloma. In sarcoidosis, it is a non-caseating granuloma. Sarcoidosis usually seen in young women, and it involves lymph nodes, lung, the common organs. It can affect other organs like liver, and all the other organs can be involved. And then Crohn's disease we have already discussed. In Crohn's disease also there can be granuloma or may not be granuloma. Then Wegener's granulomatosis, it's a vasculitis, type of vasculitis, and it is unusual disease. Now we have discussed about chronic inflammation, causes of chronic inflammation, different types of chronic, different cells involved in chronic inflammation, like macrophages, lymphocytes, plasma cells, eosinophils, then different giant cells, Langerhans giant cell, two-tone giant cell, foreign body giant cell. So each type of cell gives us a clue regarding the etiology. Then we discussed about a few examples of chronic inflammations. We discussed the important cholecystitis, then gastritis, peptic ulcer, and the most important chronic inflammation is tuberculosis. It is good to know as much as possible regarding tuberculosis, because that is a single most important cause of death due to a single organism, tuberculosis. So we have discussed all this, and granulomatous inflammation, it's very important.